So in honor of World Cerebral Palsy Day, we have 19 countries who have been, since our time, I guess if we're here in the United States on Central Time Zone, since midnight in the United States yesterday, have been having a similar conversation around the globe, one country every hour. And the topic is about function versus diagnosis and thinking. So I'm going to go ahead and share a video clip from the International Academy about the topic that we're going to talk about today. Okay. Sorry, 1 second.
Welcome to this session. We are members of the Global Professional Education Committee of the International Alliance of Academies of Childhood Disability. And as a group, we have been thinking about this topic for a little while. And this is, we've called it diagnostic approach versus functional approach. Is it really a sensible question? And what we would like to do is have a little discussion and a taster of what we've been thinking about and share it a little more broadly with you, and also hope that you will take this conversation further. So first, I would like to invite you, Peter, to tell us why we've been thinking about this and tell us a little bit more about what we are talking about here.
Thanks, Arnab. I'm Peter Rosenbaum. I'm a developmental pediatrician and health services researcher, and have been concerned that by focusing just on diagnosis, we are missing vital information which we ordinarily think about as clinicians of any sort, pediatricians, therapists, and so on, when we're asked to work with a child and family. We have a long tradition of thinking both diagnostically and functionally or categorically. And an example I use is thinking about lymphoma. When we have lymphoma, we want to know whether it's stage 1, 2, 3, or 4, because that has really important implications for both treatment and prognosis and the way we talk to the person who has the lymphoma. If I'm going to refer a child with cerebral palsy to one of you, you're going to want to know how old the child is and what they are able to do. What's their GMFCS level, for example. So the idea of focusing just on diagnosis, or quite frankly, just on function, is clearly a limitation, and we believe we need to expand our thinking.
Thank you very much, Peter. I think that is the gist of where we've been coming from. And we recognize that there are different kind of approaches globally, depending on where in the world you are. So it'll probably be a little bit helpful to find out more about how we've been thinking. So Jenny, let me invite you to say a little bit about yourself, but tell us, how are people thinking about these issues?
Hi, I'm Jenny Carroll. I'm a physiotherapist. I think it's very different across the globe how people are thinking about it, and even within different countries. It's almost like a spectrum of, some people are very diagnostic, some services are all organized really around diagnosis, and some more towards the disability. And I think that there's real positives for both, isn't it? And in some ways it's new thoughts that we're having, but also thinking about how certain disciplines have been organized for many years. Therapists particularly have been thinking more around a more approach around models that have disability, and like the occupational therapists have many models that look at the person, the individual in terms of their function and what they do, models of occupation. So I think there's some thoughts around there already, but I think what's nice around having a more disability focused is it puts the child and the individual in the center, and then the diagnosis is something that affects them and all the other different things, the environments around the model, very similar to what the ICF does really. But it's just, the diagnosis still remains very important, but it's how we perhaps move towards a more person disability centric model. But I think it varies across the globe about what people are doing and how that is working.
Thanks, Jenny. So yes, indeed, both are important, and it is about how people are thinking about and how they are applying it. And I guess once we start discussing it and trying to change how people are thinking, there certainly would be a lot of opportunities, but there may be challenges as well in how people might perceive it. So Bernadette, can I invite you to first say who you are and then tell us a little bit more about how you think what those challenges and opportunities could be.
Thank you. Yeah, my name is Bernadette Gillick, and I'm a physiotherapist and a neuroscientist. And I think this is the key point, is one question that might be asked is why change? Why shift, or why incorporate this? And models are powerful, and ways that we think are very powerful. And just as Jenny said, keeping the child at the center and thinking about the child, this is child driven. So we've got this opportunity to incorporate the diagnosis, a very important aspect of this that might direct care. But we have the opportunity also to look at what's the function of a child? How can they participate? What's their activity level? And who are all the people that are involved, the stakeholders, including the caregivers and the parents, equally as we work together to support this child throughout their lifetime. So I think that there could be a potential reticence or fear of, well, why are we thinking of changing this model, or why are we challenging a model, age-old model of this diagnostic-driven viewpoint? But I think actually, in a lot of ways, we already have been doing this. It's opening the door for the opportunity to incorporate more and to explore how can we support this child in different ways at different times throughout their life. So I'm excited that we're having this conversation and we're thinking about this from a more global perspective with the diversity of cultures, the diversity of care, and certainly the child as the center of that entire discussion.
Can I add a comment to that?
Okay, so now we're going to have a discussion, and I have invited two of my colleagues, Teresa Stuckel-Moulton and Dr. Michael Massall, can talk each about their experiences. I'm going to have Teresa start by talking about a program she's been doing for running in a group of children with cerebral palsy and other conditions, and introduce us to her program and talk about how she incorporates function and diagnosis. And then we'll hear from Dr. Massall and how he discusses diagnosis and merges function with families. And then we can all have a discussion as a group. So please feel free to comment in the chat or raise your hand if you have additional comments, because we would love to hear from you also. So I'll turn the floor over to Teresa to talk about her waist frame running program.
Thank you so much for the invitation and the opportunity to be here. It's really a pleasure to be part of an International Day thinking about this conversation and kind of how we view a variety of things. So I'm going to talk about an intervention that we've been doing with adolescents using frame running. This is a collaborative effort between myself and I am a physical therapist, and I work in the Department of Physical Therapy and Human Movement Sciences at Northwestern. And we collaborate in this program with Chicago Public Schools, as well as Chicago Run. And I'm speaking today on behalf of a number of people that have been really key players in this effort. So first, I'll just maybe introduce what Chicago Run is. It's a local organization that is really embedded in several schools within our, and outside of schools as well, within our community. And they have a focus on inclusive running and physical activity programs. So they use principles of sport-based youth development to try to provide healthy physical outlets for kids across our city. And so they have been a really wonderful partner in adapting some of their curriculum to our students that have movement challenges. So we had developed or had this idea to try to implement a frame running program here in a local Chicago context. And so Tara Egan is a school-based physical therapist, and her and myself, along with Dr. Deb Gabler, who's a pediatric physiatrist here in Chicago, had a number of goals in mind when we were thinking about implementing this program. And we'll get into those in a second, but they fall under a couple of the F's that are, I think, being commonly discussed during today's sessions. But first, I thought I might just reflect a little bit on how diagnosis might impact this, because function is very heavily influenced in this conversation. However, diagnosis is important as well, mostly from the perspective of whether or not it is safe for somebody to participate in this kind of a program. Do they have any medical complications that would make it such that it wouldn't be a great solution for them for fitness, that maybe a different alternative might be better? We look for diagnoses or individuals that would benefit from having a little bit of additional support for running. And then the other thing that we're kind of running away from, if you will, is secondary diagnoses that we know that are common in adulthood for individuals that have cerebral palsy, things like cardiovascular and cardiometabolic syndromes. And I just wanted to acknowledge that we've received some funding for our work from the Spencer Foundation, as well as the American Academy of CP and Developmental Medicine. So I thought I would give you a quick view from the saddle, as it were. This is one of our season-ending community events. So you'll see the flags there are from Go Run. It's a local community running association that hosts free weekly timed running events. And so our participants have now been part of the running community for 4 of these events. And they've chosen to do both the 1 mile path as well as the 5K path at different points in time, depending on their individual goals. And so you can just see they're in parks across the city. So it's a really nice opportunity for our participants and their families to engage within their communities for this type of an event. Okay, so just to touch on a little bit of our functional goals, fitness is one of them. The healthcare professionals that are involved in the program, this was probably our primary motivation for getting involved and thinking about how we might be able to improve endurance and strength among our participants. We do programming in a variety of different formats. So earlier on in the pandemic, and while there was still snow flying in Chicago, we did online sessions. As the weather got warmer and better, we've been meeting in parks to train outside together. And just this past month, we've integrated into an after-school program, so embedded within the context of school. And so we have kind of a motto of just keep moving. We really focus on the endurance aspect of continued activity. And we ask our participants to get in touch with their bodies and to understand their own perceived exertion. And we pair that with some heart rate kinds of measures for our own checking in on that, but we really encourage that self-awareness piece for the fitness aspect. Friends is another big aspect of this. Chicago Run has a lot of social emotional learning components in their curriculum, and so we include that as well. We have a junior coach on our team that also uses a running frame to participate. And we really value team building and teamwork within our sessions. So we try to encourage some of that informal mentorship between individuals. And you can see here, if it wasn't as clear in the video, kind of what these running frames look like. They're large tricycles, so they have 3 wheels. And they have the ability to steer, but it is the participant's leg power which gets them moving forward. So friends is a big part of this and having more opportunities for social engagement. Finally, we look at the goals that they've set and fun and being able to achieve those goals. So we have the athletes really think about what it is they are looking to achieve for their season and their participation. And then we really try to actively engage the family also in the, particularly the end of season celebration. But it's an opportunity for the whole family to think about fitness and how activity might play into their particular context. And I think that's where I'll kind of end there. I just have a couple of snaps from some of our season ending events with our athletes and some of our community leaders and their families, demonstrating some of the positive achievements that we've had, and certainly invite an active discussion during today's session. But I also have my email address here, and I'd be happy to engage further as we move on.
Thank you, Teresa. And we will have some more questions for Teresa in a bit. I just wanted to next introduce Dr. Michael Massall, who's a developmental pediatrician at the University of Chicago and is often in the position of making the initial diagnosis for some families. So Dr. Massall, if you can perhaps tell us what you think is important, how does diagnosis play a role for families, and how do you integrate the whole child and function into these discussions? And you are still on mute.
I am Michael Massall. I'm a developmental pediatrician. I'm in the Millennials train station in downtown Chicago, and I am excited to be here. I am also excited because I've had the pleasure in practicing now for almost 40 years of really seeing a revolution. And that revolution is threefold. In the old days, we would say one of two things. We would say it is always asphyxia and there's nothing we can do and there is no hope. And I've learned from the Academy, from the consortium of international organizations, from working with interdisciplinary colleagues in physical therapy, neonatal follow-up, and more, that you got to meet the families where they're coming from. And it is a complex journey, and you have to do it right the first time. So my initial encounter with doing it right for the first time is I was a fellow at Kennedy Krieger, and everybody believed that the preterm infants in the era before surfactant, if we sequentially did lumbar punctures on them, no baby would have severe IVH3-4 progressing to needing a shunt. But what we found is we stabilized babies' lungs. Our worst case scenarios of the previous generation weren't occurring, and no child needed a shunt. I don't think that was because there were some preemies who eventually might, but the transformation of the management of preterms led to a revolution. And that second revolution I experienced was preterm babies, more than 12 weeks old, who got surfactant. And we went from an era where children would spend months in the hospital, have sequential chest tubes, and be very compromised in growth. And over 90% of preterms, more than 12 weeks early, used to die. We're in a current era where 90% of children born less than 28 weeks gestation, whose mothers get corticosteroids or who get surfactant replacement, survive. And the good news is that the rate of CP in preterms is decreasing across the world. The bad news is we don't know how to count it in the United States. We don't have networks to count it in the United States. And we don't know if it's true in the United States. But because of this organization and because of our international focus on World CP Day, this is what we know. And the best way is not to talk in statistics and not to talk in the abstract. So on Monday, I saw a 24-week gestation girl, Maria. Her mom had had 3 pregnancy losses previously. The maternal fetal medicine people tried to do their best so that they could get her to 26 weeks, and that was not possible. Mom had corticosteroids on board, baby was gently ventilated, but baby had ventriculomegaly, which is an indicator of white matter injury. She had pretty severe chronic lung disease, and Mom loved her to death. And Mom had done great things, helping her feed, helping her be followed up with ophthalmology. She has some strabismus. She's going to get some alignment surgery in the next few weeks. And Mom recognized she loved music. She was curious. She was determined. She did midline hand play. Her emerging hand skills were that she could pull off Mom's COVID mask. And so, so I did a Hammersmith. I looked at the baby. I watched and asked the mother, what are your strengths? And she says, my baby is curious. My baby is socially responsive. My baby loves to turn to my voice. My baby has enjoyed doing tummy time now. I'm worried that she's not doing things with her hands and she's not rolling as much as I would expect a 6-month-old. And I looked at the whole child and I said, well, we have in the States this degree of prematurity, this degree of neonatal complications can access the eye. But I said, what have you received from EI? And the mother said, wait lists. Nobody comes, everybody's afraid. What should I do? And I said, first of all, you've been doing all the things right. Between you and extended family, you have been Team Maria. At the other end there's some other things we want to really work on, and their activity related to exploration, manipulation, self-mobility, communication. And we can do that if we involve colleagues who have that passion. And so I said, our role is function. I'm going to give you this diagnosis. You have bilateral CP. I sense your child's strengths. You have head control. You don't have trunk writing yet. You're not dominated by primitive reflexes, but the things that underlie function, feeding better, not having seizures, having intact vision and hearing, those are wonderful strengths. And we want Team Maria to help you. So I want you to think of cerebral palsy as something where I don't have the motor control for coordination. And we're going to do a variety of activity-based interventions. And I know your daughter's going to make progress. And I know your daughter's going to learn. And I know we're going to help your daughter do the 5 Fs. And I'll leave it to others to describe the 5 Fs.
Okay, wonderful. I think one thing that we encounter a lot as therapists or clinicians is that we have to sometimes write up these reports of what the deficits are or a certain label in order for them to get access to services. And I just wonder if you're a parent reading that report, how do we offset some of these things that we have to do in our current system in order to advocate for our patients with, balancing it with their strengths. So that's really open to anyone, but either Teresa or Mike or anyone through the chat, or you could raise your hand. But maybe Mike, what you do to offset that when you explain to parents about the labeling, and then how to really focus on what they can do as well.
I think there's two things. I think we have to support families in their things they're concerned about. This mother is concerned. My daughter is not using her hands as much as she should. And even though my daughter can get on her elbows and prone, she's not rolling or sitting yet. And I would like a strategy to manage that. I have her routines now for feeding. I praise this mom to death, because having a baby who was 450 grams, weigh 18 pounds at the 6-month visit is a cause of celebration. Nobody knows how hard that oral motor coordinated regulatory was. The second thing I praise her for is she, even though her eyes have a complicated strabismus, she recognizes her child's visual abilities and sensory abilities and has done activities to promote that. And then the third thing is she knows she needs some strategies to go for the next step, and rather treat it as a black box. You can use the challenges. A 6-month-old child who's not at a 3-month-old level and getting on her elbows, and not at a 4-month level doing a marine push-up, and not at a 4-month level and batting at objects, and not at a 6-month level transferring. I don't think the levels matter, but there are functional observational skills. This child is intermittently fisted, but she can unfist. She loves her binky. She can pull off her mother's mask so she can watch her mother's face. I know this kid is going to get more hand function. And so I can put it in a framework, and I can use for the systems all the challenges that she has, but I always temper my counseling, and I temper my dialogue with the family of saying, she's young, she's gonna learn, we're gonna follow her, we're gonna have Team Maria. Go ahead, Colin.
Okay, thank you. And then I guess a question for Teresa in the context of the frame running program is sort of how you are balancing diagnosis and function in this program, and maybe as your lens as a traditional trained physical therapist, how this program has expanded your idea of function and diagnosis together.
Yeah, for sure. So I think that diagnosis for us, and this is like a pretty narrow kind of situational context, I suppose, but diagnosis for us is really just about entry into the program. It's about access to the use of this device in order to do something that other kids of a similar age are also able to do. And so for us, it's just about whether or not it's safe to participate, I think, from a diagnosis perspective. Things like if you have very brittle bones, and we need to be concerned about some of that, or if you have uncontrolled seizures or other things that would just be diagnoses that would give us pause for participation. And I think that of what I presented, sort of the fitness realm of things is kind of within my comfort zone as a traditionally trained PT, as you say. And then some of the other components of it are a little bit outside of the way I thought as a student, perhaps, where I think there's a little bit more of a partnership in terms of goal setting that extends beyond just the physical domain. And I think that I really like the way that Dr. Massall talked about the framing and thinking about more of a true partnership. And actually, this is a really fun age because it's a transition of the partnership from with predominantly a parent or a caregiver to also very intrinsically almost the balance of power tilted more towards the adolescent. So they're kind of taking on the reins of being the primary driver of their scenario and their goals and what it is that they'd like to do with their free time after school, and how they might want to take control over their own fitness. And so I think supporting some of those other really apparent strengths in a lot of our athletes has been a way that actually we've kind of also benefited the fitness side of things. So by maybe one example, just by improving sense of self-efficacy and their sense of perceiving themselves as an athlete and presenting themselves as an athlete to the world, I think provides additional motivation to work just a little bit harder to get your RPE higher and your heart rate higher in the times that we're working together. And we see our athletes encouraging one another in ways that as adults, sort of more neurotypical, or however you want to say it, like we don't have movement challenges. It's harder for us to motivate them than it is for them to motivate one another. And I think that's so powerful. And so I really like how Dr. Massall talked about celebrations and kind of celebrating and acknowledging and pointing some of those things out, because I think it can have a really positive snowball effect into other areas of function and maybe diagnosis.
Yes. I was just wondering also, Mike, for the older families you work with, how diagnosis can be important for families to establish some sort of identity, but also how you encourage. And I guess my question is, I wonder if sometimes when a child receives a diagnosis, if that sometimes steers clinicians into one bucket of questions that leaves out another. And I know that that's not the case in your practice. So I just wonder what advice you give so that we don't have tunnel vision based just on diagnosis, which is important, but we also make sure we ask all the important questions as providers to make sure, do they want to be a runner or an athlete, or do they have friends in school, and these kinds of important things. So wondered if you could get your perspective as a developmental pediatrician on that. And you're muted again.
I think the most important thing is always to focus on a child's strengths, what they can do, parent and children's understanding, and set goals for success. I think the most important thing to know on the value of recreation is Special Olympics. As everyone knows, historical Special Olympics had plenty of kids who weren't doing well academically in school. What people don't know is up till 1970, International Typical Olympics, in 10 years of Special Olympics, the Special Olympians had beat the world records in both winter and summer sports of most of the Olympic things. If somebody ran a mile in 4 minutes and 5 seconds in 1954, there was a Special Olympian who had run it in 4 minutes. Now, that should teach us, do not underestimate motivation, do not underestimate time on skills that we want to do, rather than I want to be Michael Jordan and I'm going to practice 1 million jumps from half court. No matter how much I practice, I'm not going to out-jump Mike. And so I got to choose goals like I got a left-handed hook shot that can go over anybody who's tall. It only goes in 1 out of 4 times, but it surprises people, including my brothers and sisters, which I have many, and pick up basketball game. So you concentrate on having fun. You concentrate on setting goals, and you concentrate on saying, you know, this is what I'm good at. These are the things that are harder. These are the things I want to do on my own. And this is what I tried and it didn't work. Do we have plan B? And plan B is God made robots. God made alternative mobility. God made driverless cars. So you don't have to be isolated.
Yeah, I hear a lot of what you're saying. There's a lot of good points there. I think that we all know that if you have two people who are GMFCS, spastic, bilateral, grade or level 3, that they might have two different sets of goals. Maybe one doesn't want to play basketball and wants to do a running program, and then the other child wants to do something else. They want to be involved in dance or something, right? That it should be goal-based. I mean, diagnosis is part of the identity, but really each person is an individual.
My first part of my life, Colleen, I was in upstate New York, and the Willowbrook consent decree was operable. Willowbrook was a historic state of New York institution that was underfunded, under-resourced, and under activity base. And in that population of individuals who had disabilities and were said they had to go to the Willowbrook schools in early childhood, there were plenty of children with chorioathetoid CP. They had never been given communication devices. They had never been given switches. They had never been given credit for what their nonverbal and non-motor understanding was. There were several kids we found who had intact cortical function and with augmentative communication, graduated from high school, went to college, and wrote novels about their experience. What does that tell you on what we missed? What it tells you is we didn't pick up their strengths of what they could do, their eye gaze, their ability to understand, their way they tried to laugh, and we just focused on the weakness. That is a recipe for disaster.
Yeah, I agree with that. I also wanted to just point to the comment, the chat. Arnab has joined us, which is great. So we have several people from the international group joining. And in the UK, he mentions that across health education, care is often accessed through diagnostic labels because policymakers aren't always aware of current concepts. And is there a way to involve policymakers as part of the team in conversation so we can change the system and resource access arrangements? And is this an issue in your experience? So I think as far as the United States, I think it's the same as in the UK, I would argue, and anyone else can comment. I also see Rick Lieber's picture of the Shirley Ryan Ability Lab. And I was just thinking in combination with what Mike was mentioning, that disability, I think, is a medical term, but that it's really a social construct, that we're limited maybe more by environment, both attitudinally and physically, and what we believe is communication and social barriers is really, I think, at the root of what the social construct of disability is. So the Shirley Ryan Ability Lab focuses on abilities, I think, and that's, I think, a really visionary way to look at this discussion about ability and disability as terminology. Anyone else can comment on that, but I'm also going to post in the chat something that talks about this social construct of disability. So if anyone wants to either raise their hand in the discussion or comment in the chat, we'd be happy to hear your thoughts as well.
Well, somebody's feeling brave to do that. I thought I really love the idea of involving policymakers as some of the stakeholders in these conversations, because, it's I guess a growth edge for me as a researcher to understand more about, well, what are the kinds of studies or the kinds of things that would convince you that this is a more appropriate way to have better outcomes overall? And what are the measures that would be maybe useful to attach onto other studies in order to change this construct a little bit. Because I think right now, sometimes we're sort of doing dual speak where we're writing things down and documenting things in one way with a very disability sort of mindset with labels and things that make insurance companies happy. And then we're trying to switch the conversation with families to say, well, that's what we wrote down so that we can advocate for any services that you may need, but this is really how we're seeing the situation. And it becomes challenging to have like kind of dual conversations. If there's a way to kind of streamline that, I think it would help us all as professionals to kind of achieve the goals that we're looking to help our patients achieve.
Yeah. I think this sort of deficit model that we are required to use in our system has an effect on us as providers too. That we have to really have more of these kinds of conversations on World CP Day and beyond about how we can remind ourselves of this too, so that we don't get caught up in sort of this thinking. Mike, do you have a comment?
Yeah, Colleen, I would point out that some of the systems we inherit is because we have cumulative things like the ICD-9 and ICD-10 and other things. And the current health services systems haven't caught up with the ICF. The current health service systems are aware that they're supposed to be enabling and supportive, but they don't know how to get there. And I think the best example I've learned during COVID is what happened in the United States. If I was a 75-year-old and had a stroke during COVID, I got to go to rehab, I got an orthotic. If it was in my dominant hemisphere, I got speech and OT and PT. And then after I went through rehab, I would get things in the community. If I was a child with white matter injury and had bilateral CP, I was on waiting list to nowhere and I could go a year or two. And I think the fundamental equity question is what allows us to participate and not be isolated and not have as our only friends, our caregivers or parents, because those are lethal, discriminatory practices. And we can do better, and we're more aware of a society. We can do better than that.
Yeah, I fully agree. And I open it again to discussion. Okay, Arnav.
Can I briefly comment on those two issues? And I think they're very, very important. I mean, nobody is saying diagnosis is not important, because understanding the nature of a condition allows us to know how things might progress, where to look for strengths, how to plan things. So, but in a sense, there is a disconnect between what we are putting down for, in reports, in a sort of a, emphasizing disability. We shouldn't have to do that. We need to move that forward. And certainly in our field, where we're not going to cure things, but we want to focus on the right things which matter to the children and also to families, we need to be able to get that balance right.
Yeah, very much agreed.
Hi, everyone. This is Bernadette Gillick, and I am on Ellen Suter's computer. So I'm very, very honored to be on with her name. So the one comment on the heels of what Arnav just said is also there are so many different countries represented here, which is just amazing to see everybody in time zones that are even the wee hours. I know the point I'm trying to make is the consistency of the goals and the salience for children around the world and for parents around the world is really important, because that there's so many lessons to be learned from each other on these topics of which we're discussing, and how fluid they are, and how much we can help each other around the world with consistent themes. So just really impressive to look at all of us who are on this and to think there's a lot of similarities in addition to our differences. And thank you for this session, exceptional session. Thank you.
Thank you, Bernadette. A comment in here from Sebastian about the system in Ireland, that about education allocating resources not based on diagnosis, that many educators and families feel that this is maybe a cop-out, so to speak, by removing a clear label and engaging with this criticism. And how do you experience this tension in the United States? Or is it even evident? I am not sure that we have removing of labels quite yet in the United States, but there is certainly an emphasis on, I think, some positives. The strengths-based, I think, literature and work came out of the school system because they found it was more effective to motivate families and students. And also this idea of a growth mindset, that learning isn't static, that you're able to grow and build on your strengths. I think we're still label based in our educational system, but that's not really what I know so much about. So I'm opening this to anyone that might know more about our educational system and how resources are allocated specifically. Oh, Mike, you're on mute. And then Bernadette.
The most important thing educationally is to realize that all children can go to school. Up until the US passed IDEA in 1975, less than 10% of children with neurodevelopmental disability, whether you were CPID, autism, blind or deaf, went to school. So at one end, universal access has improved. Is it perfect? Absolutely not. Is it evidence-based? Absolutely not. But if you build on, everybody has a right to participate for reasonable accommodations and to have goals that are achievable. Those are the core frameworks in the United States of FAPE. Free, appropriate public education in least restricted environment with measurable goals. But the real policy issue is this: all of society does better if we don't do exclusion. There was an era where we would say, women can't go to med school, they only can become nurses, don't go there. We have done so much better on that. If we do this in enablement and we don't discriminate against children, our capacity for them to be making contributions, feeling self-efficacy, and having a life than having a stigma can take place. That's what we got to do.
Good point. Bernadette, oh, go ahead. Sorry. Teresa.
I was just going to briefly piggyback on the idea of equity, because I think we need some efficiency built into the system given the number of students overall that are being served. And without labels, then we have a little bit more of an onus to be looking at everybody and how everybody can improve their access. And I don't think that we have enough bandwidth for that. And so in order for those that are in highest level of need to get resources, perhaps that's where it kind of helps to focus a bit. But I kind of responded to that equity point a little bit. Sorry to interrupt.
Colleen, I can kind of speak a smidge about, as a school-based therapist, what we see in the United States. And I would say for us in our district particularly, so I'm a physical therapist in the northwest suburbs of Chicago in a cooperative. And I would say we do not base allocation of services on any medical diagnosis. So I don't know, it does sound like that's different than what goes on kind of internationally, but our services are definitely more based on need versus their own medical diagnosis.
Thanks, Carrie. And Bernadette, did you have a comment before also?
I didn't. I'm sorry. I waved my hands.
Okay. Okay, wonderful. All right. Okay. I'm trying to think of anything, any other comments from the group of anything we've mentioned so far. I also think that these types of discussions that we're having today, involving so many people around the globe and really talking about these issues, are another way to bring this forward. So I'm really happy that everyone joined today and that we're having these important conversations all over the world in a lot of different places. And I might just go ahead and post our listening and sharing QR code for a second. And while we decide if anyone else has any further comments before we depart here, I'm going to go ahead and share my screen in just a second. And you can use this QR code, oh boy, let's see, to give your feedback on our session.
One thing I was just reflecting about a little bit in terms of diagnosis or label, or really us as a community coming together from around the globe, I wonder if there is value for children, adolescents, families that have a diagnosis to connect with other people that have a similar shared experience that may not live down the street from them or be in their school or even their country, that you know, especially for rare disorders beyond cerebral palsy or as a component of cerebral palsy, it might be a way for social networks to form to provide support to one another, or to engage with researchers that are doing things, clinicians that specialize in certain areas. So just the reflection of so many people from around the world kind of coalescing on this call around the topic, that seems very powerful. And I wonder if there's value in that on an individual family level as well.
Yes, excellent suggestion. Okay. It is interesting also, I think now, especially with genetics and the different ways that we can label things, how that might affect diagnosis as well moving forward, and identity. Maybe Teresa, just to shift a bit, I thought it was really interesting. We had talked before about identity and diagnosis, and like how, in addition to their diagnosis, what the sort of participation-based running program added to their identity, or what the goal maybe was with that type of program to give them opportunities.
Yeah, definitely. So I think I consider myself profoundly lucky to have interacted with all of the athletes that were part of our program. And I think maybe we have a selection bias of people that were already relatively confident in who they were as a person and how they understood their diagnosis label or how it impacted their life. One of the things that was kind of interesting is we asked them kind of specifically how much they saw themselves as athletes or runners before the program, and how that maybe shifted a little bit afterwards. And I think some of the anecdotal evidence that's been really interesting to hear is things like, my whole family are runners now. Whereas before, like, oh yeah, my dad's a runner, my brother's got a lot of energy or whatever, but we're all runners now. So I think that has a really powerful additional label or additional component of somebody's identity that maybe they weren't, maybe because of another label or component, they weren't themselves expecting to add on. But it's kind of like, I don't know, like a charm bracelet or something like that, like where you can have a lot of these coexisting components. And I think it's been really nice to learn from these athletes and students and how they begin to understand those various aspects of themselves.
Wonderful. I like that as a place to end. And usually people are not so sad when we end 5 minutes early, but I'll keep the chat open and I'll put the QR code back up. But thank you all for joining. And of course, if you have more comments or please enter in the chat. And there's still more hours left in the day of more talks. So if you want to visit the AACD website to find out more talks from other countries and other perspectives, feel free to do so. The conversation continues. And thanks again for joining.
Wonderful session, Colleen, Teresa, and Michael. Thank you all so much.
Thanks, Bernadette.
It's Bernadette.
Thanks for joining. It was
Yeah.
appreciate you guys taking time out of your day.
Yeah, I'm in the lab alone right now quickly. So I just wanted to say hi and thank you. It just
And we can see your whole face.
here I am in my new lab at University